Good afternoon, everyone, and thank you for joining us today for our Cardiac Rehab Workgroup in recognition of Cardiac Rehab Awareness Week. Chelsea Andrews and I are the Site Engagement Coordinators for MVC, and we look forward to facilitating this work group for you today. So I'd like to introduce today's presenters. Today's work group will feature presentations by MVC Co-Director Mike Thompson and Haley Stolp, health scientist at Million Hearts, a national initiative that focuses on implementing evidence-based priorities and targets that can improve cardiovascular health for all. Mike Thompson is a health services researcher and assistant professor in the Department of Cardiac Surgery at Michigan Medicine. He currently serves as the co-director of the Michigan Value Collaborative. He also co-leads the Michigan Cardiac Rehab Network, which is a consortium of quality collaboratives and cardiac rehab stakeholders seeking to equitably increase cardiac rehab participation in Michigan. Haley Stolp is a health scientist in the Division for Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention. Ms. Stolp provides policy and partnership support for Million Hearts. She manages the cardiac rehabilitation portfolio for the initiative and supports other efforts to engage with the healthcare system to equitably prevent premature death or disability attributed to cardiovascular disease. Thank you, Mike and Haley, for joining us today for this work group. Before you begin your presentations, I just have some brief housekeeping to review with you. So first, this session is being recorded. Slides and the recording will be shared with the attendees following the work group. With regard to questions, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We also will have some time for Q&A at the end if you want to save your questions and unmute to ask them. Regarding our post-work group survey, your feedback is very important to us. So if you could please complete this survey in the link that will be provided in an email following the work group, that would be greatly appreciated. So with that, I am going to pass over the mic to Mike to share his presentation today. Thank you for being with us. As a reminder, if you could just mute yourself upon entry, that would be great. Thank you so much. And I will stop sharing my screen so I can pass it over to Mike. Thank you.
Great. Thanks so much, Christy. Let me get these slides up here. All right. Can you all see those? Perfect. Well, we're really excited for today. So thank you all for joining us. I'm going to talk a little bit over the next 15, 20 minutes or so about, why we're focusing on improving cardiac rehab use in Michigan and why this is a point of emphasis for the Michigan Value Collaborative. And so, cardiac rehab has been a value coalition campaign for MVC for a couple of years now, and we've made some really great strides that we're happy to share, and also talk a little bit about how we're going to take the efforts that we've made and move them into real positive change in this area. So just as a kind of brief overview, I'm going to talk a little bit just from a high level about what cardiac rehab is and why we're focusing on it. I'll talk briefly about what our goal is through this initiative and then kind of close out with how will we get there. So what is cardiac rehab? So cardiac rehab is a kind of multifaceted intervention designed for patients that recently had an acute cardiovascular episode or have a chronic cardiovascular disease. Traditionally, it's been used for patients with recent heart attack, have a kind of standard chronic heart condition like coronary disease, stable angina, heart failure, or recently had a heart procedure like a coronary bypass, percutaneous coronary intervention, valve replacement, transplant, so on and so forth. This intervention is designed to address a number of areas around. It's kind of commonly known for improving aerobic exercise through monitored exercise training, but it's also intended to improve other behavioral changes like nutrition, smoking cessation, stress management, and also education and medication adherence. Beyond that, it's also intended to provide psychological and emotional support. Often, many of these programs have support groups, and studies have shown that, and guidelines recommend cardiac rehab for many of these patients. And so this is a really useful tool for patients that have recently experienced many of these conditions. We also have a lot of data suggesting that cardiac rehab is not only clinically effective, it's cost effective. So if we compare the value of cardiac rehab relative to other interventions like beta blockers, statins, the number needed to treat in terms of the lives saved per 1,000 patients actually exceeds, in cardiac rehab, exceeds those of many other medications and treatments and therapies that we provide patients that recently experienced a heart attack or heart procedure or other conditions. We also have evidence suggesting that cardiac rehab is not only cost effective, it's actually cost saving. So the benefits of cardiac rehab can be seen kind of longitudinally in terms of reducing the need for a secondary heart procedure or for repeat cardiovascular related hospital admissions. And so the cost per year of life save range from anywhere from $5,000 to $9,000 per person, and has been shown kind of consistently to reduce hospital readmissions in the short and long term. So why are we focusing on this? I think, if we think of the mission of the Michigan Value Collaborative, which is to improve health and healthcare and sustainable health for Michiganders, I think the evidence is pretty clear. And so, but why focus on it? I think first and foremost, cardiac rehab is broadly underutilized. So less than a third of patients with a qualifying event attend a single session of cardiac rehab within the year following their discharge. This is kind of staggeringly low, considering how many other things and medications and therapies that we provide other patients. The fact that only 1 in 3 patients attend a single session is kind of disheartening. Pardon the pun. But not only that, among those that attend a single session, only a quarter of those patients complete all of the recommended 36 sessions during the year following. So not only are we struggling to get patients in the door, we're also struggling to have them continue to attend cardiac rehab when there's consistent evidence showing that there's a significant dose response relationship, that the more sessions you attend, the more effective cardiac rehab is at improving long-term outcomes, improving quality of life, and so on and so forth. And not only that is it underutilized, it varies a lot by condition. So of the qualifying episodes, patients with coronary bypass tend to do fairly well. About just over half of patients attend a single session. But there are other conditions, PCI is about a third. Patients with medically managed AMI, it's less than 20%. And for patients with kind of chronic cardiovascular disease like stable angina and heart failure, where cardiac rehab is still recommended, less than 5% of those patients attend a single session. So I think this is a really important opportunity for us as a collaborative to address this kind of really critical need. Not only that, cardiac rehab use varies kind of substantially across hospitals in Michigan. So this is an example of cardiac rehab attendance rates, so enrollment rates and attending a single session within a year of discharge after coronary bypass. And on the x-axis are all the Michigan hospitals that provide coronary bypass surgery. Cardiac rehab use ranges anywhere from about 18% to over 82% across hospitals. So not only is it underutilized, but it's all over the place. I mean, we have some really high performers that are north of 70% attendance, and we have many that are under 30, 40%. And so this is a really huge opportunity for the collaborative approach to learn from those that are really excelling and doing well, to help those that are kind of I guess low performers, or those that are struggling to get patients enrolled. And this pattern emerges across all the conditions. This is not unique to coronary bypass. This is in PCI, this is in valve surgery, this is in heart failure. And so we have a really strong opportunity to learn, and I'm sure many of the lessons that are found here can be applied not only to those hospitals in Michigan that could use some help, but also nationally. And I think we can serve as a really important model for that. We've already done some site visits kind of virtually. I think these were done about a year and a half ago. And I think this helped us to kind of learn a little bit from both those that are doing well and those that are struggling. And also highlighting that the fact that there are really important lessons that we can learn, and there are levers for improvement and barriers and facilitators that we can learn from. And kind of just briefly, we've seen that communication in the process is really important. So contacting the patient early, discussing the benefits of cardiac rehab, using cardiac rehab liaisons who serve as a kind of bridge between the inpatient setting or the procedural setting and the subsequent use. Automatic referrals, all of these things are known and shown to improve enrollment. We've seen that having strong leadership support can also accelerate cardiac rehab use. And I think this is where MVC in particular can come into help, is that we have many folks in our collaborative that are a part of the administrative side or a part of the C-suite side. And there's really strong evidence that a strong leadership support structure can help cardiac rehab programs flourish. Other factors that are really important is in terms of building capacity. Capacity constraints from a staffing perspective or for a physical space perspective can limit those. It can limit enrollment and be a barrier for many. The growth of kind of hybrid or virtual programs are things that people are exploring to increase their capacity without having to expand their space. And frankly, some patients need help, and the cost component of this is no mystery. And so some patients face these additional barriers to cardiac rehab, including costs of attending, transportation. And so I think these are all areas that as a collaborative, we can try to work together to learn best practices and to share solutions and strategies to addressing many of these barriers. So what is our goal? So we've kind of identified that our goal is for cardiac rehab participation to be 40% by 2024 for all eligible conditions. So we're excluding heart failure from this because this is kind of a different animal in and of itself, but we do have a separate goal for this that we can share outside of this session. But currently, across all Michigan hospitals that have patients that undergo coronary bypass surgery, PCI, valve replacement, transcatheter valve replacement, and medically managed AMI, the state average, or the number of patients, or the percent of patients that go to cardiac rehab, is kind of like prior literature, just under 30%. So our goal is to get to 40%. We want to see a realistic improvement that we think is attainable. There are certainly some hospitals here that are already above that goal. And we think that taking these kind of modest steps can get us to the million hearts goal, which is 70%. So that's what our overall goal is. If we get to that goal, we estimate that about 2,237 additional Michiganders will receive cardiac rehab in a given year. If we use the data from earlier, this would suggest we're going to save about $11 million in healthcare expenditures, and we will avoid 60 deaths. So there are real tangible impacts that we can make going from 30% to 40%. Obviously, the higher we get, the better, and these savings and deaths avoided rate would be higher. So we're hoping that we can get to that point and meet this mark so that we can have these kind of tangible results. So how are we going to get there? So first and foremost, we're going to be hosting work groups like this. So we're going to be having kind of quarterly cardiac rehab work groups. More information will be coming on these. You can sign up for notifications and hopefully stay tuned for this. And I think that these groups will serve as a very important function within our collaborative to help all of our members improve in this space. Also, participation in other kind of work groups that we provide will have a kind of very kind of ancillary benefits to cardiac rehab. We have a lot of work groups on chronic disease management, health equity, health in action. Again, all of those have kind of lessons to be learned that could be applied broadly, including the cardiac rehab space. So we certainly would welcome you at all of those events as well. As many of you know, MVC is including cardiac rehab participation after CABG and PCI in its hospital pay for performance program. So just as a kind of primer for the upcoming 2024 performance or program year, hospitals are able to select cardiac rehab use as their value metric, which is a component of our P4P program. And essentially what it does is we compare baseline rates of cardiac rehab participation in 2021 and compare it to 2023. So we're currently kind of in the performance year. Hospitals have already selected their measures for this. And so at present, 21 hospitals have already selected cardiac rehab as its value metric. This includes 16 hospitals for PCI and 5 for CABG. So we're really excited about this because I think this will be a really, these work groups and this incentive structure, I think will hopefully lead to some really important improvements. And again, we see this as a win-win. We can improve cardiac rehab use and hospitals can get rewarded for doing so. And so we're really excited for that opportunity. I'd also, and Christy mentioned this during the introduction, we've developed what we're calling the Michigan Cardiac Rehab Network. So this is a network or collaboration of collaboratives. It includes MVC, it includes the Blue Cross Blue Shield of Michigan Cardiovascular Consortium, or BMC2. It includes the MST-CVS Quality Collaborative, which is the Society for Thoracic and Cardiovascular Surgeons, and amongst others. I'm missing many. We've had a lot of participation from MSCVPR, which is the State Society for Cardiovascular Pulmonary Rehab, as well as many of other CQI partners. And again, the goal here is to equitably increase cardiac rehab participation for all eligible individuals in Michigan. And so we take a very similar collaborative approach. We have a kind of three-step process for this. One is benchmarking data. We provide data to hospitals to give them information on where they stand and how they can improve. Dissemination of best practices. I'll talk a little bit about the best practices document that we've created. And again, collaborative learning. So in addition to the MVC related work groups, we have many Michigan Cardiac Rehab Network specific work groups that are focused solely on this kind of from a broader 30,000 foot view perspective. So the benchmarking reports, all of our MVC hospitals already receive this cardiac rehab benchmarking report. It provides data for all of their admissions if they have those for CABG, PCI, surgical and transcatheter aortic valve replacement, medically managed AMI, and heart failure. These reports are also shared with the BMC2 Collaborative and MST-CVS Quality Collaborative. And so these collaborative partners of ours all have the same data. And our goal is to get these data to as many people as possible. And so if you don't receive these reports, let us know and we can try to figure out how to get it to you. Or if you think that somebody would benefit from getting these reports, that's been a challenge for us is how do we get these data to the right people so that they can be useful. And it includes hospital level performance data on any cardiac rehab use. So what % of patients are going to cardiac rehab, your kind of quarterly trend charts for cardiac rehab use for each of these conditions, the average days to first cardiac rehab session. It's well known that the duration between discharge and cardiac rehab attendance, the shorter the duration that is, the more likely they're to attend. So there's a lot of effort around getting early enrollment, getting people going early. And then again, the mean number of sessions attended. So again, we know that there are really strong benefits for increased attendance kind of moving on. This is an example of kind of what that page looks like. So this is for a kind of a mock hospital and cardiac rehab use after coronary bypass surgery. So again, you get your annual rate, which shows you relative to others in the collaborative, your trend line, the average number of days to first visit, and the mean number of cardiac rehab visits within 365 days. And we provide these for each of the qualifying conditions that you have enough cases for, essentially. In terms of disseminating best practices, we have worked with a number of stakeholders and experts in the area from around the state to develop some hopefully best practices for people to adhere to. This QR code does work, and so feel free to scan it. Again, the slides will be provided afterwards, so you'll be able to access it through this as well. It's also on our website, so if you're just happen to be perusing through there, it's also within our resources. Many of our members within the Michigan Cardiac Rehab Network develop these best practices, and it's based kind of solely off of the Million Hearts best practices toolkit. And what these were intended to do were to provide a little bit more detail or kind of a step-by-step, how do you do it in terms of addressing very specific issues or barriers related to cardiac rehab enrollment. So this is kind of what it looks like. So we have a table of contents, which shows all the different kind of initiation strategies, maintenance or adherence strategies, and kind of innovation models that many are looking at, including system level changes, innovative kind of different models for cardiac rehab, as well as some information on different measures that can be used and resources beyond there. This is a page. These are all designed to be one page documents, so you can print it off and hand it out. This one is looking specifically at improving inpatient and outpatient referrals. So it gives kind of like some key stakeholders or who are people that we need to work with to, as a part of this process. It gives direct contact information for the individuals that help create this document. So if you want to learn a little more from them, you are free to reach out to them. It talks a little bit about the impetus for why this is an important thing to do. And again, kind of a process step-by-step. This is how somebody went about doing it. It certainly won't be 100% applicable but to every situation, but our hope is that it provides at least a starting point for you, so that that activation energy of doing some of these things is a little bit lower. In the collaborative learning model, we are having virtual learning sessions. We're going to have our first MyCR meeting in April. We'll have about 2 or 3 of these virtual learning sessions a year, with a combination of of content experts and sharing of quality improvement strategies that folks are doing around the state. We had an in-person meeting this last October that went really well, and we had a lot of enthusiasm, and a lot of folks from around the state came to join to learn about different aspects of how do we navigate the billing cycle, how do we get buy-in from leadership to improve kind of these issues around cardiac rehab. And this is all done in collaboration with the BMC2 and MST-CVS quality collaboratives. So I'm going to stop there. I really thank you all for joining us. We really are looking forward to making some strong efforts around this in Michigan. Again, if we can get to that 40% goal, we can save a lot of money. We can save a lot of lives, more importantly. And so I look forward to working with all of you in this space. If you have questions, you can reach out to the coordinating center. I'm happy to help with those as well. And we can go from there. But Christy, do we want to answer questions now, or do we want to wait for Q&A at the end?
Whatever you think is best. We had one question that popped up if you want to answer it now, and then we can go into Haley's presentation.
Sure. So I'm seeing the one at the bottom. So are there any patients for whom cardiac rehab is not indicated? It's kind of broadly indicated. And so the best kind of response I get from folks when I hear this question is make the referral, allow the cardiac rehab facility and employees and staff to make a determination as to what the best path forward would be for an individual. And so they will often tailor programs according to an individual's already kind of level of physical activity and functionality and whatnot. So the best kind of advice or feedback we get to that question is make the referral. The cardiac rehab facility is very kind of adept at understanding kind of the broad landscape of patients. And so they can help. Their goal is to help everybody. And so they're looking for as many referrals as they can get, because they feel that they can help anyone that comes through their doors. And I'm happy, again, we'll have questions towards the end as well. And I'll be happy to answer questions in the chat. But I would certainly love to introduce Haley Stolp, who I've gotten to know over at the Million Hearts Initiative. And she's going to talk a little bit about kind of the big picture of where cardiac rehab fits within the kind of national efforts that are going on. So I will turn it over to Haley at this point. So thank you all.
Thank you, Mike. I'm going to pull up my slides here. All right. Thank you for the introduction. Happy to be with you all. Again, my name is Haley Stolp. I'm joining you all from the CDC to talk about Million Hearts activities and our work to increase cardiac rehab participation to 70%. Quick disclaimer, the comments are those of my own and do not necessarily reflect that of the CDC. All right. As a moment of interaction, going straight to the data, use your heart indication if you can. There's a little reaction button at the bottom, and it would give you a chance to highlight your response to the question. Please use your heart reaction if you know someone who's had a heart attack or stroke. I'm sure many of you do. You all see patients in and out. And I'm putting my heart up, although it's not visible. Seeing some hearts pop up. Great. And keep your heart open if you know someone who died from a heart attack or stroke. Get my hands raised. Seeing few hearts. Yep. So for me, it was my grandfather. He died from his second heart attack at the age of 70, which is my dad's current age. So when you think of the lives lost, our work is really impactful in helping to reach these folks and extend the life expectancy. And it makes sense because heart disease remains a leading cause of death. So these are 2021 provisional data mortality. Heart disease is, of course, our leading cause of death in the country, followed by cancer and COVID-19. And we know heart disease is largely preventable. About 80% of cardiovascular events can be prevented. So a lot of opportunity here. Heart disease is also the leading contributor to racial disparities in life expectancy. And it costs hundreds of billions of dollars every year in medical expenses as a result of heart-related efforts. We also see disparities in heart disease rates across the country. These are data showing 2018 to 2020 of adults ages 35 and older by county. And we see the darker red is having the higher mortality rate in the South, unfortunately. And it's creeping up there a little bit in Michigan as well. So we do see quite a lot of heart disease death rates across the country. And unfortunately, our progress in heart disease mortality reduction has declined. So it's flattened. So that the slope has declined since 1970s. We've made some tremendous progress in heart disease prevention. And now we see the flattening and decline since 2011. So strokes is about completely flat. And we see a rise in heart failure related mortality, which is concerning. We attribute this largely to the rise in diabetes and obesity. But overall, a lot of opportunity for us to gear up and see how we can further steepen that decline in cardiovascular disease mortality across the years. And these are old data. So these are 2016 data here. If you will, bear with me because I think it's still relevant. You see the causes of death in the first column here. Heart disease is the biggest leading cause of death, again, with cancer followed. The second line is Google searches. This is public Google searches on health-related topics. And that little sliver at the top is where we see heart disease. Stroke is in the green here. And then you see media coverage by the New York Times and the Guardian. Again, heart disease is very, very small. And if these data were reproduced today, I would argue we'd see about a similar trend. So we've got a lot to do to bring cardiovascular disease to the attention of the general public. So that's where Million Hearts comes in. We were established in 2010 and launched in 2011 to prevent 1 million heart attacks and strokes in 5 years. We've now in our third iteration of the initiative, if you will, and we're targeting to prevent 1 million heart attacks and strokes by 2027. So that's by December 31st of this year, 1 million heart attacks and strokes. And we've done some considerable modeling data to indicate how we can get there. Million Hearts is an initiative led by CDC and CMS, that's the Centers for Medicare and Medicaid Services. And we work through our public and private partners. So we really leverage partnerships across the country. We work to convene champions such as yourselves, facilitate impactful collaboration, just like MVC has been leading, implementing evidence-based strategies. I'll mention the cardiac rehab change package in a moment, engaging to address health inequities as well. And that's leveraging some new policies, some processes and other strategies to help build equity in cardiac rehab participation. This is the framework of the initiative. So we have a three-pronged approach. The first is building healthy communities. This might be what you think of as a traditional public health role, if you will. Our target is decreasing tobacco use, decreasing physical inactivity, decreasing particle pollution exposure, and all of that is done with an emphasis on reducing those indicators by 20%. So we've got a target to reach in order to reach that 1 million events prevented. Moving on to the optimizing care in purple, this is what we engage as more clinically relevant activities. We focus on the work in ABCs, that's aspirin or anticoagulant use, improving blood pressure control, improving cholesterol management, and smoking cessation. Those are the ABCs of Million Hearts for which we've worked on since the initiative began. And you see the last component that we'll be speaking to today, increasing use of cardiac rehabilitation. As you saw on Mike's slides, a huge opportunity for saving lives using the cardiac rehab as an intervention. And across our public health and clinical portfolio, we have a focus on health equity for 5 priority populations. And today, again, I'll be speaking about our cardiac rehab efforts to reach a 70% participation target and how that work relates to helping build participation in cardiac rehab equitably, focusing on improving outcomes for people from racial ethnic minority groups, people with behavioral health issues who use tobacco, and people with lower incomes, and people with living in rural areas or access deserts. So diving in a little deeper into our optimizing care portfolio for increasing cardiac rehab, we focus on supporting the automatic referral, care coordination, hybrid cardiac rehab models, other program redesigns, and largely the strategies from our change package that I'll speak to in a moment. We also have some efforts underway to improve coverage for cardiac rehab to bolster participation. So I'll dive into our portfolio. There's 6 activities that we actively engage on to improve cardiac rehab use. The first of which started in 2015 with the establishment of the Million Hearts Cardiac Rehab Collaborative. This was an effort underway to gain some momentum. So there were about 30 organizations and a number of cardiac rehab graduates themselves that were part of this original cardiac rehab collaborative. Excuse me. The CRC came together to highlight some of the key strategies to help move the target, and they set the charge of reaching the 70% participation rate. In 2017, they published this paper. It was really our roadmap, if you will, for the CRC, and that's getting to that 70% target and highlighting those strategies. And a way of doing that would help increase participation to 70%, would save 25,000 lives, prevent 180,000 hospitalizations, and that's every year in the United States. So that was our target, and that's what we continue to strive for. I do want to highlight Stephen Catane as one of the founding members of the CRC at this time and a big contributor to our work. The Million Hearts CRC continues that aim of 70% participation. We focus on strategies developed in our annual action plan that we revise every year, and we convene on a quarterly basis. We use these opportunities to engage with a number of people across the country. It's very exciting. Sometimes I get a chance to communicate a hospital in North Carolina to a hospital in California and say, you guys are using the same EHR system. You want to collaborate on establishing automatic referrals? Those are the kinds of coordination that can happen across the CRC. But largely we disseminate information and resources, highlight opportunities for engagement, including some quality improvement projects, facilitate collaboration across state, local, and national efforts, as I mentioned, and they're recognizing those top contributors and celebrating their achievements as well. Recognition has been a key construct of the Million Hearts success. And then also we increase access to national and international experts, bringing them on to the CRC, answering questions, and helping to mobilize some of the efforts underway. Oh, I'm sorry, I just realized I'm not moving the slides here. All right. The action plan objectives. So this is what we operate for the CRC. It includes these 5 priority areas, and they've stayed the same since 2018. It includes a communications component, increasing use of best practices, and that's, again, related to our change package, building equity and cardiac rehab participation, increasing sustainability, affordability, and accessibility through innovation, and measuring, monitoring, and reporting progress. So the CRC started with about, I think it was 50 members in 2015. We've now expanded to 580 individuals across the country with 280 organizations or agencies represented. And our quarterly meetings has about 120 members participating, but we've got a lot of engagement through our emails and other activities. And as you can see, our membership is very diverse. We've got a number of patient advocates, cardiac rehab patients themselves. We've got clinicians, policy developers, a number of payers. So our policy is really all are welcome as long as you have a commitment towards that 70% target. These are some of the high-level achievements of the CRC over the years. So I won't go through the full list, but we're very excited to have opportunities to develop some communication materials, to highlight some key articles and presentations, and really break down what that means for the CRC, how to translate that science into action. We give a number of presentations, and that includes grand rounds and other types of events. And then we also help promote and leverage some research funding opportunities. One activity was the development utility of the HEDIS measure. So that began in 2020. We now have 2021 Medicare Advantage data using the HEDIS measure, and it's been really exciting to see where that participation rate has moved around, and then going to those payers and finding out what they're doing right. How have we achieved that high exemplar cardiac rehab initiation rate? A couple other examples of our accomplishments from the CRC. So we engaged deeply with AHRQ's Take Heart initiative. We've had some communication activities. Again, we continue to work with payers and purchasers, highlighting opportunities for CMMI models. So there was a cardiac rehab incentive payment model that has since been canceled, but there was a lot of engagement in helping building that model. And hopefully you can dust it off the shelves one day and bring it back. Advancing some comments on CMS rulings, so promoting those opportunities to comment on those rules as well. The CRC again is open, and we'll put the link in the chat for if you care to join. I'm happy to have you all. Moving on, we also developed and maintain national cardiac rehab surveillance. So in 2017, we had our first MMWR publication on cardiac rehab use, and there was a surveillance methodology that was developed to help inform this process, and we made that available. So we have it currently on our website. This is the second version, and a third version will be up, I believe, by the end of March, very shortly. And thank you to all those, including Mike Thompson, for input on the development of the third iteration of the surveillance methodology. And this has really been helpful to help engage other payers, other health systems that have access to claims data to assess their participation rate. Not everyone has those data at their fingertips. I know MVC has been really helpful in having those data very much actionable. I think Mike touched on some of our latest outcomes for the surveillance of the country. So this is a paper published by Stephen Katan and colleagues. And again, 29% participation rate among Medicare beneficiaries, and only 8% of those that attended, 8% attended those 36 sessions of all people eligible. So we've got a long ways to go to reach that target of 70% participation, which is actually that 29%. That's the initiation rate that we're looking at. It's at least participation in one session. And again, we keep seeing these consistent disparities by race and sex. And we have a couple of strategies that we're highlighting in the revised change package that I'll mention in a moment to help address and narrow those gaps. These are the data by state, and then you've got your data breaking out even by hospital, which is amazing. But wanted to highlight Michigan as being about in the average across the country, 30% participation among Medicare beneficiaries. And again, the average was about 29%. We also have a online platform. This is publicly available and anyone's use. Oops, not moving my slides, sorry. Not easy having two formats here. All right, this is the interactive atlas where you can access the Medicare participation data. You can also access eligibility data, completion data. It's by county. I pulled up the Michigan map. The yellow triangles here are cardiac rehab programs that we gather from data from the American Hospital Association. So always welcome. People are actually using these data to inform their research, which has been really exciting to see come out. And there'll be a third version of this platform that's supposed to be a little more user-friendly, will be coming out by the end of March. So stay tuned for that. I believe the link will stay the same though. Moving on, we identify and promote best practices to increase cardiac rehab participation. So I mentioned the cardiac rehab change package. This came out in 2018. We worked across the country to gather 105 tools and resources, and we build those into a structured change package approach. This is the Institute for Healthcare Improvement approach for quality improvement. And we have change concepts that are large constructs, change ideas that are specific actions, and then we take it to the tools and resources to help implement those strategies. And we develop those tools and resources in collaboration with colleagues across the country, across 18 states, 22 institutions, and 36 professionals and researchers. And I'm thrilled to say we have a new iteration, a second edition of the change package that are coming out. We're saying late May, probably early June. We're really excited to have a new version of the change package. It's going to include some content on building the case study for cardiac rehab, highlighting some new staffing models, adding some tools for automatic referral and care coordination that were developed by our colleagues in TACART, that AHRQ initiative, strategies to build health equity in cardiac rehab enrollment. And here's where we pulled some of the strategies actually from the Michigan Cardiac Rehab Toolkit, some new tools for hybrid cardiac rehab programs, and new strategies to engage with heart failure patients, which takes a bit of a different care process than some of our traditional cardiac rehab efforts. So stay tuned, happy to send that all out to you all when it is live. I will say there's about 100 new tools added to it. So it's really kind of a doubling of the previous version if you're familiar with it. Moving on, we support and engage state and local partners. There's funding opportunities that were sent out, and this current funding opportunity ends in September 2023. I believe a new version will be coming out in the next few weeks, also having an innovation component. We're not sure how it might relate to cardiac rehab, but really exciting opportunity. We'll be sure to share with you all as relevant. And we've been able to highlight some hospitals across the country. We have a recognition program called the Million Hearts Hospitals Program, where we highlight hospitals that have achieved exemplar in not only cardiac rehab, but other efforts to prevent cardiovascular disease. There's an application to submit. It's an open evergreen application, so you can apply at any time. This was one hospital that actually partnered with their state local health department, using some of those funds I mentioned earlier to develop a hybrid cardiac rehab program that has since been very successful. So we're happy to always amplify and recognize those successes. Finally, we have a funding opportunity that also went out with our colleagues, the National Association of Chronic Disease Directors, highlighting some health equity efforts. And one of the 6 awardees is St. James Healthcare in Montana. And they were focusing on addressing care deserts for rural health, for rural heart patient, addressing care deserts for people with heart failure, and that includes a cardiac rehab component. So they're building a new cardiac rehab program to better serve heart failure patients in rural areas. Oh, one more opportunity for state engagement. So this was a tool developed in collaboration with the American College of Cardiology chapters. So we actually met with some of the chapter heads, and they wanted to engage with Million Hearts, not sure how to engage easily. This was a tool helping them to click a focus area, build out their goals, work on their first steps, and establish some champions and other efforts. And the second page of this tool, you see we highlight our cardiac rehab materials to facilitate that engagement and partnerships with AACPR state affiliates, quality improvement organizations, whatever is available. I know Michigan Value Collaborative, you all have a whole great trajectory underway, but there's other states that need a little more help helping to find some partners. Fifth is advancing development, validation, and adoption of new cardiac rehab delivery models. This is a publication we highlight showing the gaps in cardiac rehab access. So all of the gray spaces here do not have a cardiac rehab program. This is a big equity issue. We also know that if we were to fill the capacity of all cardiac rehab programs in the country, plus 10%, we could only serve about 45% of eligible patients. So that's not going to get us to our 70% target. So we really know that developing new models is going to be key to the success of Million Hearts and our work in cardiac rehab. So this is the paradigm shift we're looking to drive towards. Traditional cardiac rehab being expanded, so more people in the in-person cardiac rehab structure. And part of that is also the expansion of the hybrid cardiac rehab you see there in gray. And then we anticipate there'll still be some folks that are left out of cardiac rehab or for whatever reason are not able to participate, but really expanding our capacity using hybrid programs. So with this in mind, we had a cardiac rehab think tank that we convened in October of 2020. And these are the outcomes of that collaboration. We focused on a new terminology for the new models, which were published in the Alexis Beatty et al. Paper. This is the publication here. The blue highlights with the blue section here. Core components of cardiac rehab. This will be a paper coming out, I believe, later this year, highlighting those core components. This is a revision of the Beatty et al. Article of 2007. There's some new policy efforts underway. This largely takes out, outside of CDC, but there's a number of works and new laws that are being developed and informed to extend access to virtual cardiac rehab, and that's that synchronous audiovisual communication component for cardiac rehab. There's also some health equity efforts, including expanding Medicaid coverage. So we have a number of states across the country that do not cover cardiac rehab for Medicaid enrollees. There's an opportunity there to engage with state Medicaid agencies. Implementation approaches. This was really the Kickstarter to Stephen Katayan's paper highlighting how you develop a hybrid program, design and implementation structure. And then earlier this year, we had a paper come out highlighting the evidence gaps for research and research needs. So we continue to monitor these publications. We have an ongoing collaboration with some of the key partners in each of these sectors. And finally, we work to amplify key messages about the value of cardiac rehab. So going back to that, that graph, those bar graphs, we've got an opportunity to highlight cardiac rehab as a really high impact evidence-based strategy, and it's under use across the country. So we've got a web page, we've got a communications toolkit where you can get access to these kinds of e-cards from cardiac rehab graduates. We're now working with clinicians to develop some new e-cards. We're also looking for a heart failure patient. So anyone that has a heart failure patient that you think has completed cardiac rehab or is currently in cardiac rehab that might have a story to share, happy to connect with you to gather some new e-cards to highlight those patient successes. And then of course, our cardiac rehab collaborative is another opportunity for ongoing communication, and we do some social media activities as well. And my last slide, I would be remiss if I didn't acknowledge all the contributions of the Michigan partners. So again, Stephen Katayan has been a real key foundation of a lot of our efforts in this way, along with his colleague Robert Berry from Henry Ford Health System. We mentioned Mike Thompson from University of Michigan. I also keep in contact with Mark Fendrick. Dr. Fendrick has been a great supporter of cardiac rehab and engaging it with value-based insurance design programs. I know George Keepa has since left Blue Cross Blue Shield Michigan, but he was also a key contributor to our work. He volunteered to present on a number of webinars. Holland Hospital, and there's one other Michiganer here that's not listed, who came to us from Holland Hospital, Megan Gross, who I think is on today's meeting. really instrumental in the work of the Cardiac Rehab Collaborative over the past year and the development of the change package. She's the second author of the change package there. And then finally, the Michigan Cardiac Rehab Network, again, for which the tools in that toolkit, we've incorporated in the revised change package and other works like Michigan Value Collaborative. So huge thumbs up from Million Hearts. Thank you for your efforts, and you're really leading the way. And thank you.
Thank you so much, Haley and Mike. Those are really informative presentations. So I'm going to turn it over to some questions now. I see that we answered most of the questions in the chat. We have one question that came in that wasn't directly answered in the chat yet from Dr. DeLucia. Can you go back to the state rates of cardiac rehab usage? I'm curious to know what states are best performers and suggestions as to why.
I'm going to pull up that slide here. So, Mike, I welcome your comments as I'm looking for this slide. I'm not sure why it's having a hard time to pull it up.
Yeah, I mean, I guess the first thing I'll say is I don't know as if we really know why. I think there are it's so much of what we've seen, at least in Michigan here, is that it is very much practice to practice and hospital to hospital. And so I suspect the same could be said for state to state. And so I think, I'm guessing for some of these like Nebraska, Iowa, South Dakota, these are obviously much smaller populous states. I think we often see challenges in large urban areas in terms of access. And so that may be contributing to it. I'm sure there are differences in demographics that may be contributing to it. So there's probably not a single thing that's adding to it, but I suspect that we really don't have a good sense of why some of these places are doing really well compared to others.
It's curious that this is Al DeLucia. It's curious that the top 5 there are actually, top 6 are actually fairly rural states, which kind of makes the argument, that it's not, that it'd be interesting to see what the distribution of cardiac rehab is in those states, because you would think that those rural states would be a transportation issue. And apparently they still have high penetrance of doing, look at the number of cardiac rehab facilities you have in Wisconsin compared to Michigan.
Right.
Or in Iowa. Look at Iowa.
Yeah.
I don't know how many millions of people Iowa had. I think when I was a resident there, they had like 2 million people in Iowa, and then maybe 5 million now, but there's more pigs than people in Iowa. But yeah, I mean, that's incredible. So they've got, every county almost has cardiac rehab. So that tells you something. Although South Dakota was one, that's a little sparser. Nebraska is quite sparse. So maybe that isn't the only thing. Maybe it has to do, some of it has to do with patient compliance. I don't know.
Could be also cost sharing for Medicare, could be very costly. Sometimes, $20 to $40 per session, and that accumulates as many sessions you go to. So imagine some economic barriers as well. As well as the referral. Unfortunately, we've seen some both implicit and explicit bias in cardiologist referral of cardiac rehab. And sometimes the training of a cardiologist can dictate whether or not cardiac rehab is a key component of the care, even though it's in the guidelines.
Do we know if there are any differences in the cost sharing in those states compared to the states that don't have a lot of cardiac rehab?
I don't for Medicare Part B, but I am happy to say that we are exploring the Medicare Advantage data for 2021 right now. And interestingly, the top 5% of performers in cardiac rehab initiation for Medicare Advantage plans are in Wisconsin and Minnesota, mostly. And seeing all those payers' engagement in Wisconsin, I've actually just sent an email to the Wisconsin colleagues recently asking them what's going on here. What do Medicare Advantage plans in Wisconsin have that the other plans don't? So we're just now exploring those data.
And Al, in terms of the the cost sharing component, I think we've been working on some data, and it seems to suggest that while cost could be a barrier in terms of initiation, the real challenge with cost is in adherence and in getting to 36 sessions. And so patients that we found that patients that have higher copays tend to not attend as many sessions, because that kind of accumulating cost as you go to each session is kind of a larger component. So, if you have a $20 copay for your first session compared to a $30, that may not change your decision for the first one, but it may change your mind when you go from 23 to 24 or 24 to 25, because you're adding $10 every time you go. And so that's where we often see challenges, is in that kind of the number of sessions attended.
Right. And that's an absolute, truth that you're not going to, an economic decision-making individually at that basis. I mean, that's pretty straightforward. It's interesting that, that there's a dose response curve too. So that's the idea to get at it, is that there seems to be a dose response curve to cardiac rehab. So while people think they can maybe go to 1 or 2 rehab programs and then do it on their own, it's like taking 1 or 2 piano lessons.
Yeah, exactly.
Awesome. Do we have any other questions from the group? If you could raise your hand if you have a question, and then maybe when you unmute, if you could say your name and the organization you're from, that would be great.
I'll take a chance to ask a question to Haley, which is, we're doing stuff obviously within the state here. So I guess, how can we as a state and as a collaborative be helpful to the national efforts? And what are things that we can do to help kind of inspire change elsewhere?
Thank you, Mike. One key part is contributing to the change package, for which you've already done. We actually include a visual, the example of the visual of how you can use a dashboard to use data to improve outcomes for referral, for participation, and adherence. So seeing the visual of what it looks like as a dashboard, that's going to be an improvised change package of what others can replicate, hopefully, as resources permit in different regions. I'll also share your leadership of surveillance informing our surveillance methodology plan. And just now we're starting to explore the opportunity to have hospital-based Medicare data shared across the country using your model. This is coming from Michigan. So thank you for your leadership in that aspect as well. And what's really exciting is we're just now seeing other regions starting to collaborate. So I mentioned a lot of states have an American Association of Cardiovascular and Pulmonary Rehab. That's the AACPR Trade Association for Cardiac Rehab. But we're starting to see collaboratives kind of develop organically. There was a new collaborative just recently developed, led by Michigan, with Colorado's engagement in Montana. And we'll have a speaker on the next Cardiac Rehab Collaborative speak to how that organization came to be and how they're facilitating their own networks and sharing best practices to bolster participation.
It's great to hear.
I have a question, Haley. Can you speak to what unique program components are a part of the CDC Million Hearts campaigns to address the rural disparities?
Yes, yeah. So the initiative really aligns with the virtual cardiac rehab component. So I mentioned the value of hybrid cardiac rehab. We're saying virtual because that's what CMS blessed, and that's the synchronous audiovisual that maintains the requirements for direct supervision of cardiac rehab, which is currently billable for Medicare through the end of the public health emergency. So unfortunately, in April, I believe is when they anticipate the end of the public PHE. We actually will be discussing this on our Cardiac Rehab Collaborative meeting next week, what that means, what folks are going to do, how states can pivot, and it might be more engagement with commercial payers. And while Medicare potentially expands the opportunity for virtual cardiac rehab, but I know there's a number of policy and advocacy level efforts underway to preserve that reimbursement for virtual cardiac rehab models. So right now we're really focusing on that virtual and remote cardiac rehab pieces. And monitoring and seeing how programs are starting. So unfortunately, during the pandemic, we estimate, this is a paper from Drew Kazi and Marilyn Verghese, highlighting the drop in number of cardiac rehab programs. So we lost about 200 programs during the COVID pandemic. And a lot of these programs, it's hard to sustain a cardiac rehab program, as you all may know. Reimbursement for an exercise physiologist is pretty low, but the revenue that's come in from cardiac rehab is just not sufficient to keep a lot of these programs operating. All of these are discussions we're having underway.
And I think that's really it's a really important point, because I think that's where having strong leadership and buy-in from your C-suite and administration, because I think, Haley, what you said is, the reimbursement is low, which it is, and I think you have to have a good buy-in to know that the cost savings may not be coming from the cardiac rehab per se, but it'll be coming from saving those costs down the line. And so, and I look forward to the business case component of the change package, because we get that question frequently, which is, how do I even sell this to my administrator that this is important, and how that, giving resources here will be helpful and make a good business case for it. So I look forward to seeing that.
I love the name of the Michigan Value Collaborative, because it's the value piece as well, right? So
yep.
I mentioned the value-based insurance design, and it was promoted that cardiac rehab is one of the 8 highest value services to be covered with zero cost sharing. There's only 8 in the whole country that was compiled in that summary. And qualified plans are encouraged to cover cardiac rehab with zero cost sharing because it's inclusion in that criteria. And this is the VBID-X model, is what was developed as these are the 8 highest value services, and there's a whole list of low value services. And if you increase cost sharing for those low value services, you can decrease or eliminate cost sharing for the high value services. And that's the VBID-X construct. I will say also, looking at those Medicare data, the Medicare Advantage data that just became available, one of the payers that we found that had $0 cost sharing for cardiac rehab is also partnering with a big ACO, the Intermountain Healthcare. So I think ACOs might also have some lessons to share with us, and we're just now having conversations with them as well.
That's all great information. I did not know that we lost that many during the pandemic. That is quite detrimental. So thanks for sharing that information. I'm curious about those who are on the call today. How many of you are familiar with your, nearby or local cardiac rehab facilities? If there's any other disparities you're seeing in your patient populations for cardiac rehab utilization or access, or if there's any challenges that you've seen in, getting patients to complete their cardiac rehab that we haven't already touched upon today. And feel free to just unmute or put your comments in the chat.
Nice. I see the question about the high value services. I'll put that link in the chat in just a moment here.
Okay, great. I don't see anything else coming through. So with the interest of time, I'm going to go ahead and share my screen. I have a few last minute items to address before concluding the work group. Thank you again, Haley and Mike. Those are great presentations. So I'm going to share my screen quickly and bring it back. Do you see my PowerPoint?
Yeah, I've got the full view. There you go. Now it's up.
Okay, great. So I just wanted to share some upcoming events with the MVC. In addition to what Mike had mentioned of our goal of having quarterly cardiac rehab work groups, we do have these upcoming work groups at the end of February and the beginning of March. And then we aim to have 2 per month. So we have our health equity work group on February 28th at 2 p.m. with guest presenter Carol Gray from M-Shield, as well as a preoperative testing work group on March 15th at 1 p.m. with presenter Hari Nathan, who is our director at the Michigan Value Collaborative. You can register here via this link. Again, these slides will be shared after the work group concludes. So I wanted to take the time. Thank you again. Thank you to our presenters. If you have any questions, please feel free to reach out to us at the email listed here. Additionally, if you or someone you know may be interested in speaking at an upcoming work group, please contact the MVC engagement team via this email as well. Thank you all for your support of the MVC, and we look forward to seeing you at future work groups.
Thank you, Haley. Thank you, Mike.
Thanks, everyone.
Have a great rest of your day, everybody.